Ladies and gentlemen, welcome to the third edition of the World Congress on Virology and Infectious Disease. It is an honor to present my study titled 13 Cases of Pulmonary Pneumocystis in HIV-Negative Patients. Pneumocystis jirovecii, ubiquitous fungus, causes the serious opportunistic disease known as pulmonary pneumocystis, which primarily affects immunocompromised individuals. Initially described as a severe disease in the early 1960s, it remains rare until the AIDS epidemic in 1982. The prognosis for PCP remains poor and appears to be increasing among HIV seronegative patients, solid organ transplant recipients, those treated for hematologic malignancies, mainly lymphoproliferative, patients with autoimmune or inflammatory disease, and those on long-term corticosteroids. These pneumonias are associated with higher morbidity and mortality compared to AIDS, 13% to 16% versus 10% for HIV-infected patients, underscoring the need for early detection and treatment. The aim of our study is to analyze the clinical and the paraclinical characteristics of individuals with PCP and identify the known HIV immunodepressions most at risk for this infection. This is a 2-year retrospective study of patients with pulmonary pneumocystis. The study was carried out in the pneumology department of Hassan University Hospital in Fez, Morocco. The patients included are subjects aged 50 years and over, of all sexes, recruited from the pneumology department of Fez University Hospital over a 2-year period. Only HIV-negative patients were included, with HIV serology performed in all PCP cases. We excluded HIV-positive patients. Data were collected from patients' computerized medical records. Analysis of clinical records included epidemiological data, age, sex, and date of onset, history, in particular immunosuppressive disease, and immunosuppressive treatments received. The clinical, biological, radiological, and microbiological data of the PCP episode were collected, as well as the treatments received and their evolution. Data entry was performed using Microsoft Excel, and analysis was performed using statistical package for the social sciences version 25 and the epidemiology laboratory of the Faculty of Medicine and Pharmacy of Sidi Mohammed bin Abdullah University. All patients who participated in the study gave their consent, and data were collected anonymously. Data confidentiality was ensured during data collection and processing. As a result, total of 13 cases were gathered, with a 6 ratio of 8 males to 5 females, 1.6, and an average age of 55.23 years. The median age was 59 years. Third of patients, 30%, reported actively smoking. The underlying diseases responsible for immunosuppression were as follows. 1 case had Guillain-Barré syndrome with end-stage renal failure on chronic hemodialysis, having received 5 boluses of cyclophosphamide followed by azathioprine. 2 patients had a common variable immunodeficiency. 1 patient had carcinoma of the left breast and had been receiving chemotherapy for 6 months, and the 5th patient had idiopathic fibrosis, non-specific interstitial pneumonia fibrosis on long-term corticosteroid therapy that started 2 years previously, combined with azathioprine for 1 year. The median period from the onset of symptoms to the diagnosis of PCP was 28 days, with a range of 5 to 62 days. In 5 cases, the beginning was gradual. In 8 cases, it was sudden, with an average time between the onset of symptoms and the diagnosis of 17 days. Clinically, all of the patients were dyspneic at the time of management, with 11 of them experiencing respiratory distress. Of the patients, 85% also had productive cough, and 77% of them were feverish. In terms of biology, the mean circulating lymphocyte counts was 1920 cells with a median of 16-14 cells. In any cases, CD4 cells were not counted. The serum-reactive protein level was 132. On thoracic computed tomography CT, 10 patients had diffuse bilateral pneumopathy with ground glass areas in 6 cases and condensation foci in 4 others. 2 cases had an atypical appearance with pleural collection, and 1 case had sequelae of bronchial dilatation. This figure are for a 67-year-old female patient's CT scan reveals diffuse ground glass regions throughout the center and periphery of both lung hemifields. With the exception of 2 cases where examination of the bronchoalveolar lavage fluid was required, all diagnoses were based on the isolation of Pneumocystis jirovecii in the induced sputum. The cytobacteriological examination of sputum and bile fluid analysis revealed no co-infections in any patients. An average of 29 days passed between the onset of symptoms and the beginning of treatment. Trimethoprim sulfamethoxazole was administered orally to all individuals. 1 instance of cotrimoxazole intolerance was noted with the emergence of fixed erythema pigmentosa, which prompted the drug's withdrawal to try tolerance induction before suggesting an alternative in the event of failure. Corticosteroid medication was given to 8 individuals who had PCP. The mean room air arterial oxygen saturation for patients who received corticosteroid